So welcome everybody to today's gathering circle, our quarterly gathering circle. Today we're going to hear from the SDPI program at United South and Eastern Tribes. This is a good place to learn about what's going on, the happenings in THPS. So if you have any questions, feel free to raise your hand or unmute yourself and ask. And at the end of the presentation, and if you will, go ahead and enter into the chat your name and tribal location. That would help us out with attendance. And I have nothing else, so I will turn it over to Dietrich.
Thanks, Brian, and I'm excited to be here, a little nervous. So just bear with me as we get started. So today we're going to be talking about the SDPI program, Special Diabetes Program for Indians. Specifically, the title is Understanding Diabetes Program, the Special Diabetes Programs for Indians. I am Dietrich Taylor. I am the Area Diabetes Consultant. Also serve as the USET Diabetes Control Officer. We also have, as a part of our team, D'Angelique Lister. She's our program coordinator, public health program coordinator. We have Michelle Scarlotta, who serves as our project administrator. And then we also have Alexis Goddard, who serves as our administrative assistant. And we are a team. We work together. And the goal is always to help our tribal citizens, tribal nations, and our tribal citizens live more healthful. So our learning objectives today, first one is to describe the SDPI program for Indians, Special Diabetes Program for Indians. And the second one is to discuss the SDPI best practices. We're going to talk a little bit about required key measures and the opportunities to use data to aid in program development and activities. And then last but not least, we're going to talk about diabetes, self-management, education, and support. And we're going to talk a little bit about a pilot project that we're working on with one of the tribal nations in our IHS Nashville area. Okay, so Special Diabetes Program for Indians. Next slide, Brian. And you probably heard this and seen it several times in response to the diabetes epidemic among American Indians and Alaskan Native. Congress established the SDPI program in 1997. Funding for the program first went out in 1998. Currently, as it stands, there are 24 funded programs across the IHS Nashville area. USET has 20 sub-grantees, and then there are also 3 IHS units. Well, actually, that's changed. There's only 2 now because you have the Catawba Indian Nation and you also have Wampanoag Mashpee, but then the Mi'kmaq Tribal Nation has switched to compact contracts, so they're no longer IHS. And then you have 1 direct grantee, and that is the Eastern Band of Cherokee Indians in North Carolina. Next slide. So currently, SDPI is funded at $150 million. About $130 million are actually dispersed to the IHS areas for activities across tribal nations who are currently funded. And in order for those funds to be divided, the $130 million, the funds are there's a funding formula used at the national level to disperse those funds to the IHS area. And then once those funds come to the IHS Nashville area, there's another funding formula, which is similar to the national formula, is also used to divide funds and spread those out or send those out, disperse those out to grantees across the region. Another thing about SDPI funding is that they are mandatory funding. There's discretionary and then there's mandatory. And mandatory basically means that these funds are guarded by laws and regulations that cannot be changed without an act of Congress. And then you also have discretionary funds, which are a lot different. It's just the opposite of mandatory fundings, meaning that Congress can, at any point in time in that process. That's why you see the longevity in the SDPI program. Like I said, Congress enacted that law in 1997. Funds have gone out. Funds first went out in 1998, and we find ourselves 25 years later in that, still in that grant opportunity. Next slide, please. All right, so let's get into the purpose of the SDPI. So the purpose of this program is to provide diabetes treatment and our prevention activities and our services, also referred to as activities and services for AI and AN communities. Also, activities will be aimed at reducing the risk of diabetes in individuals, providing high quality care to those with diabetes, and are reducing complication of diabetes. Next slide, please, Brian. Okay, go back one for me, I apologize. Okay, right there, yeah. So let's talk a little bit about this, especially when you get into activities and initiatives and programs across the region. What you'll find is programs are very diverse in how they offer services and what services they actually offer. Some of the larger tribal nations, you'll see, you can see robots in hospitals and x-rays and MRIs and podiatrists, where some of the smaller tribal nations, they do what's called PRC. So a lot of the services are provided out. One thing that's really important in the SDPI program as the THPS, as the program director, is site visits, right? So site visits are real important to let you help you understand what's actually, as I put it in 3 words, and I call it 3 Ps. One, it lets you know what's on paper, and it lets you know what services are provided on the ground, and then it also connects you to the people who are actually providing those services. Again, it's the paper that's submitted, so the applications and the reports, and then it's the program activities that are actually happening at tribal nations. And then too, last but not least, it connects you to the people who are actually implementing those services on the ground. I always tell the tribal nations when we visit, it's not an I got you. Like sometimes when they say, well, Dietrich is coming or the team is coming to do a site visit, people start to get nervous. And that's never the case. It's never, I got you, I'm trying to find something. It's actually just the opposite. It's I get you, I'm trying to see something. It's actually a perfect marriage of, I'm trying to see the marriage of, or the perfect marriage between what's on paper, what's being provided, and then what are the people saying about the services that's being provided. So providing site visits, like I said, is never a contentious situation, nor is it for tribal nations to be nervous. It's for us to better understand the programs and see where we can actually provide assistance to tribal nations across the regions. All right. Next slide. So as part of the SDPI program, you have leadership at the tribal nations. You also have leadership at IHS. But a part of that process, and we don't really talk about this a lot, is the Tribal Leaders Diabetes Committee. Next slide, Brian, please. So this committee was established in 1998. It makes recommendations to the IHS director on broad-based policy and advocacy priorities for diabetes and related chronic conditions, as well as recommends a process for distribution of SDPI funds that we actually spoke about earlier. In that space, an example of one of the things that TLDC is a proponent of, and that is to hold current grantees harmless and only allow, this is something they submitted to IHS, only allow new applicants if additional funding is available, right? So we're going to talk about that a little bit more in depth as we talk about USET's role as a SDPI primary grantee. But again, the goal is so that the voice of tribal citizens and tribal nations are heard as it pertains to what's needed in Indian country as it pertains to diabetes care, prevention, and treatment. The TLDC consists of the following members: one elected or duly appointed tribal leader from across all 12 IHS areas, serves as primary representative, and then there's also an alternate to serve in the event that the primary is unable to attend and or be a part of meetings in that particular piece. Okay, so again, there's 12 IHS areas. Each area has a duly elected, usually like a tribal chief or a tribal administrator elected by tribal citizens to serve as a representative on the TLDC committee. Next slide, please. All right, so also a part of that process is co-chairs. So one of those 12 elected TLDC members and a federal employee serve as co-chairs of the TLDC committee. Currently, that would be Ms. Connie Barker and as a member, and then also it is Carmen Hardin as the federal employee. We, the TLDC rather, have meetings. They have quarterly in-person meetings, and because of COVID, they've been doing those virtually. And we also, they also hold quarterly meetings, in-person or virtual, and then we have bi-monthly calls. Chief Lynn Malerba was our representative for the Nashville area, but now it is Chief Sabatis and the alternate is Nancy Johnson. And so we'll be looking forward to working with them. Our next the TLDC meeting is December the 6th or 7th, and that's going to be in Phoenix, Arizona. Next slide, please. All right, so we're going to talk about USET's role as a primary provider of primary grantee of SDPI funding. So since 1998, when funds first went out, USET, United South and Eastern Tribes, have been a primary grantee with 20, like I said earlier, sub-recipients. Beginning with the 2023 SDPI grant cycle, USET will no longer be eligible to apply as a primary grantee. Right? So additionally, the 2023 SDPI grant cycle will be open and is open to all federally recognized tribes to apply as primary grantees. So what does that mean in our area? I'm glad you asked. So that basically means that the 20 sub-grantees that we currently have are now applying as primary grantees, as well as new tribal nations, new federally recognized tribal nations were able to apply as well. So earlier I said to you all that there were 24 sub-grantees or 24 grantees that were receiving SDPI funding, right? So now that's potentially going from 24 that we currently have to 35 tribal nations and organizations based on the applications received from our area. And another thing that's really important in that space is that, remember I was telling you about the dollar amount? So the dollar amount, the $130 million that comes to our area has not changed. The only thing changed was the amount of tribal nations and organizations that were actually eligible to apply, which could potentially decrease resources to the tribal nation, which is something that USET as an organization has written to and pushed against, as well as the TLDC committee. So those are some of the things that you're seeing on the advocacy side from TLDC and from USET. So although our role is changing, our support role will not change. We'll still be here to provide site visits. We'll still be here to provide trainings and support from the SDPI team at USET. Next slide, please. Okay, so let's talk about best practices. So every grantee has to select a SDPI best practice. So every grantee has to apply or select a SDPI best practice. And so a part of that is a required key measure. The best practices are focus areas for improvement of diabetes prevention and treatment outcomes in communities and clinics. One thing that I like to say in that particular space is that it's the tribal nation who decides what best practice they're going to choose based on, the needs of their own tribal nation. And then they also report back that required key measure. The one thing that I've seen as a part of the SDPI program is whether you are in Nashville area or if you're in Navajo area, the required key measure is the same. So it shows consistency in data across the entire nation. And so I always say this to our friends who maybe don't understand what the work that I do or the work that we do is that because of some of the technologies that are out there and the way the reports come in, the SDPI program and Native American data has some of the strongest data in the data world to actually speak to what's happening as it pertains to care and education at for tribal citizens and at tribal nations. And again, like I said before, each best practice requires a required key measure, and the tribal nations themselves decide what that best practice is, and then everyone. So say, for instance, if you choose diabetes education, everybody across the nation that selects diabetes education reports on that same required key measure. Next slide. So these are best practices. Aspirin and other antiplatelet therapy. You get into blood pressure control. You get into chronic kidney disease. You get into dental exams. You get into depression screening. Like I said earlier, you get into diabetes-related education. And the measures that are used to define outcomes, like I said, are consistent across the whole nation. The whole nation. So everybody's reporting on the same requirement and the same measure, which builds to the importance of and the potency of SDPI data. Next slide, Brian. Again, these are some of the other best practices that tribal nations and programs can choose: eye exams, foot exams, glycemic control, hepatitis C screenings, and then the immunizations that you see there. Okay, next slide. Next thing we're going to talk about is, and it's our final point today, is something called diabetes self-management education and support. Next slide, please. Thank you, sir. Diabetes is a chronic disease requiring day-to-day management by diabetic patients. I always tell people that most diabetics usually see their doctors every 90 days. But there's a period between seeing a doctor and going home and dealing with diabetes that a client and or a patient, as I say client, need to have the skills necessary to daily manage diabetes so that when they get to the doctor's offices, what the doctor sees as a part of that client having diabetes is them taking their medication, them understanding what diabetes is, and being able to manage that on a day-to-day basis based on the things that they encounter. Providing diabetes education and support to individuals at risk for diabetes will help reduce the risk of type 2 diabetes and other health complications. We know eye exams, amputations, we know eye issues, heart issues, a lot of these comorbidities you see with individuals that have diabetes. And so also in that space, we know that, and it's been proven that an individual with an A1C, if you catch them and that you find their A1C between 5.7 and 6.4, and get them acquainted with a program or enter diabetes education program, they can prevent and or delay actually getting type 2 diabetes. Next slide, please, Brian. So it involves teaching behavioral skills necessary to make informed decisions about diabetes management every day, like I mentioned a second ago. It's about collaborative goal settings, problem solving, follow-up, and supporting people with diabetes to make informed choices about areas that they have identified as a concern to them. My wife is a diabetic, and I've said that to numerous audiences, but my wife is a diabetic. And I always tell people that diabetes and marriage don't necessarily go together. So I actually sent her to somebody else for them to have that conversation, because what I think is important, what should be important, may not be what she thinks is important. So her being my wife, I try to just yield to whatever she wants to do to some degree and let one of my friends take care of my wife. It encouraged people with diabetes to consider their own plans and goals and identify how they will overcome any challenges that they feel are challenges and are necessary for them to better manage their diabetes. Next slide. It's an interactive relationship-based approach. While these tools change, what will never change is your support and meeting individuals where they are at and where they are at in their lives. So what does that mean? Again, I try my best, not even try my best. I always ask my clients, what do you want to see change? What's on your mind? What I see on paper or what I think may be based on medications or some of the other things that I see, that's what I see. But it only becomes important that it's always important, that I yield to the client and what they feel like is important, because that's where you're going to see the most change in a patient's behavior and our goals. We ask open-ended questions. We take time to listen to individuals intently. We're talking about family members, we're talking about support, we're talking about resources, we're talking about community, we're talking about jobs. And we speak directly to our patient and use a non-judgmental approach. So I'll ask you the question, it's a rhetorical question, and you already know. We're in October right now, and we're getting ready to go into the holiday season, right? So one of the things that I'm very mindful of is, different holidays that are coming up and different foods surrounding those holidays, right? So if like my favorite cake in the world is a red velvet cake with pecans on top, like I automatically know during the holidays, that particular cake is going to be cooked about 3 or 4 different times, and that I am going to partake in that cake at least 3 or 4 different times. So when my clients come in and they tell me their likes, and I ask them, what do you like? Chocolate cakes or bread puddings or whatever it is, I'm not judgmental and say, well, hey, don't do that. You can't have that. You can't do this and you can't do that, because when you tell a person that, it basically amps up their ability to do maybe what they don't need to do. So what I try to do is in that space is say, hey, listen, how about you have some of that? That would be great. Just watch how much of it you actually have. Make sure you're taking your medication. Make sure you're doing all the other things, and set some goals with that client that they feel like they can actively participate in and achieve. Like I said, acquired by challenges, acquired by obstacles that a person may have, i.e. food insecurity, transportation, literacy, mental health issues, and how these affect diabetes management. My hometown just got a Piggly Wiggly after 10 years without being without one, with being without one, right? So people had to travel 30 and 40 minutes to get to the local grocery store. What if they didn't have transportation? What if they didn't have dollars to pay someone to get them to a local grocery store? So, and even get medications. So all of those things go into, come into consideration when you're working with individuals and providing diabetes self-management education. Next slide, please. So we provide basic nutrition education. We offer interactive nutrition opportunities such as cooking classes, grocery store tours. We offer things like, I'm seeing these things offered like veggie bucks at the tribal nations within their programs. These are some of the activities and initiatives that you see in diabetes program across our region and even across the nation. Be aware the patient may have issues getting enough food and or nourishing foods. And then also in that space, know what resources are available to the best of your ability. Evaluate again the patient's food insecurity, accessibility, affordability, and nutritious food. And one of the thoughts that I put down as we were going over this is, if Brian walks in the store and his money is limited, which is not, and he has a choice of buying a pack of bologna and making 20 sandwiches, or buying a pack of chicken breasts and having access to 2 or 3 breasts, and he's going to pay way more money, which is more viable, which is he more likely to do? He's going to probably buy the pack of bologna because he's not just feeding himself. Sometimes he's more than likely feeding his family as well. So it's like, I can't go in and say, well, hey, you don't need to do that. You need to do this, or you need to, you know, we can't impose our thoughts and our wishes on our clients. We can only make suggestions based on what's actually there. So that's a point as well. Next slide, please, Brian. Medication and self-monitoring. Oh, man. So talk about food, physical activity, and medications and their effect on blood sugars. Also encourage individuals to follow their medication plan negotiated with their provider. I can't tell you how many times I have clients who can't tell me what medications they're on, right? So I have clients that can't tell me if they're a type 1 and or a type 2 diabetic, right? And so you spend time listening, like we talked about earlier, and sitting down and you're negotiating with that client. Hey, can I get you to take your insulins? Or what's preventing you from taking your insulin shots, or checking your sugars? So those are things that have to be negotiated. And there are also things that have to be sometimes corrected. If you go to 5 different doctors, especially in the PRC world, if you go to 5 different doctors and you get 5 different prescriptions, are there any contraindications? Is that one doctor looking at everything else that's on your team? So you spend time looking at those regimens and understanding what the capabilities are of the individual in front of you. And that's real important as pertains to medications. Encourage self-monitoring of blood sugars as indicated by your patient's provider. Also knowing that CGMs out there now, continuous glucose monitors, understanding what the ramifications parameters, not ramifications, but the parameters are actually getting an order for a CGM so that you don't have to stick your fingers as much, and those type things. That falls under find out the resources available for referrals, also certified diabetes educators, and also case manager. A good thing that I've seen across our region is that all of those things are available to our tribal citizens, to the tribal citizens that we serve. But as an educator and as a part of a diabetes program or as a part of a clinic, those are things that you need to know about resources that are available to the tribal citizens that you serve. Next slide, please. Get to know your physical activity resources. One of the other things that we see a lot of in diabetes programs are things like gyms and or access to gyms in local communities. And some of the costs are incurred by SDPI programs, fitness coaches, exercise physiologists, there's hiking and there's biking. And again, like I said, a local fitness center that's available to tribal citizens. And there's also, like with your elder center, sometimes the elders don't have to necessarily go to the gym. Programs will pay for activities and initiatives inside the elder centers and at schools. So all of those things are super important. Recognize that there may be challenges to being active during inclement weather, especially up north. There will be, but there are ways to actually do it inside. And what I tell people is, if you're taking care of your grandkids, that's physical activity. If you're walking around the house, if you're going to the mailbox, that's physical activity. And the goal is 30 minutes a day, 5 days a week. That is like one of the standards for getting physical activity. So just 30 minutes a day, 5 days a week can go a long way in preventing and or delaying complications of diabetes. Finding out if childcare is available. Yeah, I want to come to a gym, or I want to come be involved in hiking and some of the other things that's happening, but I have to care for an elderly adult, my parents, and or I have kids and I can't get there. I don't have anyone to keep them. So a lot of the programs have situations where those services are available as well. Next slide, please, Brian. Behavioral health and healthy coping. Screen for depression. If diabetes is your right hand, then depression is your left hand. A lot of times they go hand in hand. And so it's imperative that you screen for depression, substance abuse, and domestic violence. The one thing about DSMES is you start it by having a one-on-one with the client. That helps you understand that client, but it also helps you build a relationship so that you can have those unpleasant, uneasy conversations. So if there's domestic violence going on, that you can get that individual, they feel comfortable telling you, first of all, and that you can get them the help that they need. Again, assess challenges and obstacles that the person may have in dealing with diabetes. This could be related to stressors such as finances, job status, relationships, caregiver responsibilities, and other issues. Next slide, Brian. We talked about this earlier, so I won't spend a lot of time because I want to get to the point where we're asking questions, but take time to listen to the patient's experience and coping with diabetes-related problems. I'll tell you all this real quick. I had a client come in one time and they were, I was not being judgmental. I'm never judgmental. I'm wide open. You tell me whatever you want to tell me. And so we got to the point of asking, I was like, so how do you cope? She said, I've had issues with depression. And I was like, tell me about that. And she started the open-ended question, tell me more about it. And she started to tell me about it. And I said, well, listen, I said, what do you do to manage, depression? What do you do to help? I say, are you on any medication? She's like, no. She said, I smoke marijuana. I was like, wow, okay. Felt good that she was comfortable enough to tell me that. Most people in my hometown know that my brother's the police officer, right? He's the chief of police. So she smiled and she told me, she said, I know who your brother is, right? I said, well, listen, my brother's not in this room, so whatever you tell me is whatever you tell me. But that is her way of coping, right? And so in that space, am I supposed to say, hey, you don't need to do that. You don't this, that, and the other, on and on and on. I can't impose my thoughts and my reality on my client. So I only listen and said, hey, listen, if at all possible, I said, maybe, don't do it as much, and what ended up happening was after a few months working with her, she came and she told me, I never really talked about it again. She came in and she said, Deidre, I don't smoke weed anymore. Great. But you have to give them room to move towards goals that they set. If I would have said that, it would have been a closed door situation and I would have cut off the relationship that I was building with a client to actually make recommendations. So that's all I was saying in that space. Coordinate care and follow up with patients as needed. A warm handoff, it means the world. If you find out somebody's being abused at home, there's domestic violence, and you say, oh, here's a number, what guarantees are they going to actually dial that number? So if you can build those relationships with those individuals and those programs, then that's the best situation to getting that client the help that they need. Continue on, Brian. Wow, so DSMES is a partnership. The person is the expert about his or her life, their knowledge, their strengths, their challenges, and their goals to that partnership. And they know, what they're able to do, and they know what their competing demands are. The clinician or the educator has the expertise as it pertains to diabetes prevention and management techniques, has thorough knowledge of tools and resources available, and has appropriate support skills. I always tell people, I don't have to know everything. I just need to know as much as I possibly can individuals who may operate in that area, and be able to have a relationship with them so that we can connect the dots and get tribal citizens the help that they need. And last slide. Right. So why did Dietrich talk about so much about diabetes self-management education today? The reason is because USET, the DSMES program that we work in, and the team that I work with, we're working on becoming a DSMES umbrella organization. What does that mean? There are two national credentialing organizations. There's the American Association of Diabetes Care and Education Specialists, and there's also the American Diabetes Association. You go through a process of meeting set standards, and once you meet those set standards, you are considered an accredited and or recognized diabetes provider, diabetes education provider. Once you receive that designation, then you can actually bill for diabetes education and support services that you provide. We're excited to be working with the Coshada Tribe of Louisiana as part of this process, so that as we become an umbrella organization, they will become a recognized and or accredited provider of diabetes self-management education for their tribal citizens and at their tribal nation. And then we'll be working with them and Encompass to actually help make sure that the services they're providing are actually billed and realized so that those dollars are resourced and put back into the program and add to the need of add to the needs and care for the tribal services citizens that are there at that tribal nation. So we're really, really excited about that. Having said that, I think I reached my time. Is that the text message that you just sent me, Brian? All right, good. Okay. All right. So now, thank you all again for the time. I really, really thank my team for working with me. Thank you for this opportunity, and look to answer any questions that you have about anything we presented today.
Do we have any questions for Dietrich or his team right now at this time?
Should I ask a question?
Sure.
Is it silence? Is it a moment of silence?
No, go to, please ask away.
I think I've asked you a lot of questions, Dietrich, but when you're talking about, your wife and being able to, follow this journey with her with diabetes and how hard it was, just curious about the support groups and things like that that are out there for, diabetics or family members.
That's a great question, Bernice. And the thing about that is, when you look across the region and you look at the SDPI programs, there are a lot of services and there are a lot of groups that gather to talk about and help individuals with diabetes. There are walking groups. There are church groups. There are elder centers, as they're called. They meet and they talk about diabetes, and they share ideas and they share recipes and they share experiences as it pertains to clinicians and some of the services that's being provided. So, but as it pertains to my wife, like I said earlier, my conversation with her is, hey, sweetie, how you doing? What's your A1C? As long as it's close to 7 or below, then that's pretty much the extent of my conversation, because I don't want to get kicked out. Yeah. So what was the question? I'm sorry, I missed that question that was in the chat, Brian. Thanks for that question, Bernice. Did I answer your question? Okay, all right.
It was, how do you tell a native person not to eat too much fry bread?
I don't know because I'm eating it with them. It goes back to it goes back to, especially with those the tacos that they do. Oh my goodness. It goes back to talking about letting them set the goals. Remember I said about the person that told me they smoked marijuana? I didn't get in too far into that. I talked about not necessarily not doing it, but just sometimes I'll just say eat till you get full. Because sometimes we just, as individuals and as people, we straight stuff. And we go to sleep and we wake up and we eat it again. So the goal is just enjoy it. Take the time to taste the flavors, appreciate what it is, but just don't overdo it. And when you talk to people on that level, they're more apt to operate and eat in a way that's, conducive to an individual with diabetes. Yeah.
I was laughing at that because I had a mindfulness meditation once that we did, and we just sat there and, we tasted the flavor and, things like that. But yeah. But the thing is with intuitive eating, they tell you have those things that were like, oh my God, I can't believe I just ate that cookie. I'm gonna die. I'm gaining so much weight or whatever. So with that intuitive eating, they're, eat as much as possible, but still, it's a hard balance, especially when it comes to fry bread.
There's definitely a balance, but I think the idea is as we recognize the ability, and that it's actually that's only a piece of the puzzle. Are you taking your medications? What was your sugar like before? What was your sugar like? So that's what they said. They don't say diabetes; they say sugar. What was it like before you actually even had the cookie? You know what I'm saying? Are you taking and checking your insulins? In my wife's case, are you sneaking and getting a Diet Dr. Pepper and you haven't had your medications and all the other stuff that goes along with it today? And the other important part, and it speaks to something you said earlier, Bernice, and that is involving family members, right? So I might not say, hey, baby, did you get physical activity in the day? I'll say, hey, let's go take a walk. And we'll walk a mile. If my kids, at the family holidays and there's 3 different turkeys and 3 different hams and all the other stuff that go along with it, I will take my kids and I'll take my nieces and my nephews and I'll show them old houses in my community from our ancestors and where they used to live. I'll show them, I'll walk down to the pond and say, hey, I didn't learn how to swim in a pool. I learned how to swim in a pond and we had cows. But it's physical activity and it's knowledge of previous is knowledge of our ancestors. And I think that's really huge. And this job has taught me that the importance of knowledge of your ancestors and knowledge of and the importance of respecting elders, and even in the African-American community. And that's something that I'm able to communicate with my family members and the ones that are coming after me. So that's really, really huge. Yeah. Other questions?
Oh, can I just ask one more? Sure. So what would you say for the younger generation that, older people, well, I say older, I'm going to say me, I'll use myself, but we're doing all these blood tests now to figure out what's going wrong, why is this, why is that? We're really interested in, our health nowadays, but the younger generation really isn't. My son could give a crap less, I'll never hurt, I'll never get sick. But what are some of the things that they should look for when they're talking to their family care doctor?
So first of all, let me tell you, we have to be examples, right? So when I leave the house and when I was really in the weightlifting and doing all this crazy stuff that I was doing, I could leave the house at 10 o'clock on a Friday night and my kids knew Dad's not going to hang out with his friends, nor is he going to a club. He's literally actually going to the gym. So even in that space, I'm developing good habits just by being an example of, what to do. And I think it starts with us, you know what I'm saying? And going to the doctor and getting those baseline data, but then also working towards goals ourselves. And I think as we do that as examples to the ones that are coming behind us, I think that's going to actually help them to do that. My kids, they work out. I have a 14-year-old and a 20-year-old. I always say they want all of our money and none of our advice. but they definitely watch, you know what I'm saying, what we're doing. So as we develop those good habits and as we take better care of ourselves, I think it's going to be incumbent on them. They'll do the same thing. Yeah, just by watching us do it.
Great. Thank you so much, everybody. Thank you, Dietrich, for a wonderful presentation. Great comments in the chat. We'll save the chat, so I'll send that to you, Dietrich, so you can look over it.
Okay, thank you. Thank you.
And thank you all for joining.
Brian, last thing I got to say, thank you to our team. I have a great team. D'Angelique, Michelle, Alexis, Layla, you, the whole data team and helping pull this thing together. We could not have done it without y'all. And I appreciate working with y'all. And have a great rest of your day and have a great rest of the week. Oh, go JSU, go Jackson State University. It's homecoming weekend this weekend. Yeah, I got to say that.
Yes, Karen, I will send the slides out to you. I don't have your email address, so Dietrich, can you send the slides to Karen?
We'll send it to all the diabetes coordinators. We'll make sure that she gets it.
Okay, great. Thank you. And that is all that I have. Thank you. And join us for next month or next quarter's gathering circle. Thank you all.